From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello, everyone. Welcome back to the JAMA Oto podcast series. I'm your host, Paul Bryson. I'm a laryngologist and director of the Cleveland Clinic Voice Center. I'm really delighted today to be joined by my colleagues, Dr. Yaël Bensoussan and Dr. Anaïs Rameau. Dr. Rameau, motivated by her grandfather's battle with laryngeal cancer and dysphagia, Dr. Rameau pursued specialization in laryngology. At Weill Cornell Medicine, she established New York City's first multidisciplinary dysphagia clinic. Her research, yielding 56 publications and 11 grants, focuses on geriatric swallowing dysfunction, cough, and voice acoustics as disease biomarkers. Dr. Rameau has notably contributed to addressing healthcare disparities in laryngology, developing innovative, low-cost technologies, and collaborating on AI applications in our field. Recognized nationally and internationally, she has mentored numerous students and professionals. My other colleague, Dr. Yaël Bensoussan, is the Chief of Laryngology and Assistant Professor in the Department of Otolaryngology Head and Neck Surgery at the University of South Florida Health Morsani College of Medicine. Under her leadership, the USF Health Voice Center was established and became the first of its kind on the west coast of Florida. Dr. Bensoussan is the co-principal investigator on a multi-million-dollar NIH-funded grant from the Bridge to AI program. This is using voice as a biomarker of health, and it's a multi-institutional study regrouping 12 institutions to build a large-scale, ethically sourced human voice database to help diagnose disease. She also co-chairs the steering committee of the Bridge to AI program. Dr. Bensoussan, Dr. Rameau, welcome to the podcast.
Thank you so much.
Thank you, Dr. Bryson.
Well, today we have a very exciting topic, and I'm really looking forward to what you guys have to say about this. We're going to look at voice as a AI biomarker of health, and we're going to introduce the concept of audiomics. And this is a special invited viewpoint to the journal. And to most of the listeners, if you consume any of the lay press, we are seeing more headlines about AI and machine learning being able to predict certain disease states and monitor things. So if you'd be so kind, could you provide just a little background on audiomics and the premise for the Bridge to AI program?
Yes, of course. Voice has always been a biomarker of diseases. I was a speech pathologist, for example, before being a laryngologist. And speech science has existed for a long time. We've analyzed voice to understand diseases better, but the problem was that we couldn't analyze voice fast enough. We couldn't analyze a large amount of voice fast enough. And now with machine learning and artificial intelligence, we're able to really analyze a large amount of voice data very efficiently and allow machines to really understand what we call biomarkers. To give very tangible example, for example, if you look at depression, a number of sighs like or of pauses can be a biomarker of depression, right? So an acoustic biomarker of depression. When you think about Parkinson's, patient speaks a lot slower, right? Or in a more monotonous fashion. So these are biomarkers of voice biomarkers. And the concept of audiomics is more than just acoustic analysis. When we talk about audiomics, it's really like genomics or other omics or proteomics. So taking this acoustic analysis, but also integrating it with other omics, right? How do we integrate voice, but also with vital signs, for example, or with movement or with other health information to really understand better what voice has in terms of impact on disease.
So we use our voices every day, as you said, and more, most people have some sort of smart device. The voice is very available, if you will, for analysis. If you could, is it just as simple as, hey, we can say a few things in a free speech fashion, unscripted? Is that data good enough? Where are we at with I think you alluded to the quality of the data. I think there's no lack of unstructured data. Can you tell us, sort of where are we at with voice as a data point? What's available? How would we possibly activate around voice?
So that was really the motivation for writing this viewpoint, because we first wanted to highlight the need for setting up standards for this new domain of audiomics. And I say new, though it's not really new, as Dr. Bensoussan pointed out. This is a long-standing field of interest. It's been decades. But the problem with the science in this field has been really the lack of large data sets, the lack of standards in how we collect voice, cough sounds, speech data, and a lot of variability in the data sets. And now that we're in the age of AI, there could be multiple approaches in how to perfect our ability to predict disease based on voice and speech biomarkers. We could have very large and messy data sets labeled in some perfect or imperfect way with disease, and try to predict based on that. But then you would need very, very large numbers, and it's very difficult to create these data sets. Another way that our team is doing with Bridge to AI is to really set up standards and really think about also mechanisms of disease and how can we collect voice and speech samples that make sense in terms of the science of what we understand, how we understand voice and speech science, and how voice and speech and respiratory sounds can be affected by disease. So that's why work we've been doing has been around setting up protocols and standards for recording, and also for really determining what subjects should be saying and what tasks they should be performing. So I think that's probably the more likely way that we're going to make some advances in this field. During COVID, there were some very large cough sound data sets that were created, but they were extremely messy. And so it seems that creating these unprotocolized data sets is less efficient.
If I can add one thing about where we are right now, what we're trying to break also is that if you look at the literature out there, there's really amazing group working on voice and speech biomarkers, but they all work very independently. So historically and traditionally, people who work on Alzheimer's disease, for example, that's a separate team from people who work on cough or respiratory disease. That's a separate team from people who work like you and I and us laryngologists on voice disorders, for example, and ML. But I always explain that, in these studies, for example, if you look at Alzheimer's disease and voice, they'll take people who have Alzheimer's and people who don't have Alzheimer's. And in their control group, they're going to exclude anybody who has a vocal cord pathology, anybody who has a change in voice due to other reasons. So you come with sometimes, Dr. Rameau talked about very messy data, but sometimes the problem is the opposite, is that the data is too clean. So you have these data sets with very clean data, and in real life, that's not how it works, right? People without Alzheimer's can have other diseases. So in our project, what we're doing is we have protocols that are an hour long where we collect a lot of information. And for example, for a patient with vocal cord paralysis, we get VHI, but we also get a GAD-7, which is a questionnaire for depression. We also get neurological tests to see if they have a concurrent diagnosis of early dementia, for example, to really for that all the usual exclusion criteria, right? So all the other papers will have exclusion criteria. We want these exclusion criteria to become confounders that are analyzable in our data set, if that makes sense.
Yeah, I appreciate that. That's a really good point. You got me thinking a little bit too, along the scales of like what's real life. Both of your works have talked about representation in the data sets. Can either of you speak to that a little bit? I think of the example of you hear about some of these AI or machine learning mishaps where the biases are really exposed in a very significant way where certain populations are affected by the algorithm.
Definitely bias in AI is a big problem, and there are different ways to tackle it. First, I think that when you're creating your training data set, you need to make sure that you include a diverse range of individuals, especially in countries like the United States, where we really have people from very diverse origins and a great diversity of cultures. It's really, really important to collect those different voices and speeches. And in fact, I will quote the work of my colleague, Dr. Alison Konoke at Cornell, who during her PhD thesis looked at automated speech recognition and how well it performed on different racial groups in the US, and found that automated speech recognition performed less well on African American speech. And so that was a little bit of a surprise, but that's exactly why you want to collect a diverse data set. Now, it becomes a little bit more complicated when you're going to train your algorithm. It's not that clear that it makes sense to actually label the data with sociodemographic information, because the problem is that those data may get overemphasized and the algorithm may start learning to associate some of these sociodemographic factors with certain disease outcomes. And so you don't want to bias the algorithm in making those associations too strongly. So right now, there's a little bit of a debate in AI and biomedicine as to whether that should happen. And then very importantly, as I mentioned, the algorithmic auditing is very important. So after you've tested and validated your AI algorithm, you also need to make sure that over time, as you're training it more and it's incorporating more data, that it doesn't become biased as it's evolving over time.
Yeah, that's a great point. As you were describing this, I was thinking about clinical trials, right? There's goals for a phase 1, a phase 2, and a phase 3 trial before something goes out to, the marketplace or to patients. Is there equivalent in the AI or machine learning space with data auditing and learning? Or is just the paradigm different and maybe it's an ongoing audit that consumers can be aware of?
I think that's very interesting. I think we have to talk about what's happening in research papers first, right? And then when we talk about FDA approval, it's completely separate. So when we look at what's in the literature right now, when an algorithm learns and we report accuracy, we have to talk about training, test, and validation. And these words are important. That means that the algorithm is learning on a fixed data set. Okay. So let's say my algorithm is 98% accurate. It means that it's accurate in recognizing it's within the same database. And a lot of papers that we were looking at in the last, 5 years were only doing that. Now the papers that are coming out there are starting to talk about external validation, which is very important to understand. So external validation means I'm taking a completely different data set and I'm running my algorithms and I'm going to see if I get the same accuracy. Okay, so for example, Dr. Bryson, you have a data set of patients at Cleveland Clinic, and I have a data set of patients at USF, right? So you train your algorithm, you validate your algorithm, and you test your algorithm at Cleveland Clinic, and you get 90% accuracy at diagnosing vocal cord paralysis. You can publish that, or you can make a better paper, right? Saying, well, I took my algorithm and I took Dr. Bensoussan's data set, and my accuracy dropped maybe, 5 points, but it's still pretty accurate. So that brings another layer of saying that your algorithms work. Now, if you translate that, and obviously number is important, right? The more sample you have and the more diverse it is, the more your algorithm will be able to be transferable and externally validated versus if you only train on 50 white males with vocal cord paralysis, probably when you bring external data set, it's not going to perform as well. So a good algorithm, right, a good solution will continue to learn as it goes. The problem with the FDA right now is when you submit a solution to the FDA and an algorithm, it's not dynamic, it's static, right? So they have to look at the data set and approve it. And then the approval process takes forever versus what we really need to be better, right, is have algorithms that learn continuously with data that we add, if that makes sense. So that's one of the things that is limiting the true integration of these AI algorithms in what we do.
Yeah, it seems like just like computing and data, they're not static. Whatever the evolution is, or they used to say Moore's Law or whatever, it seems like a one-time approval just doesn't make any sense in this space, right?
Yeah.
Yeah, thank you for, talking about how dynamic this space is with the data. You did have me thinking about privacy a little bit. I totally agree. The more validation we can do on diverse data sets or data sets at your organization, my organization, or others, what are some of the barriers that you're aware of with regards to data sharing and privacy?
Regarding privacy, obviously, that's always a concern with AI. In fact, even with de-identified data and data that we think we would not be able to link up to individuals, there's been research that has found that hackers would be actually able to identify who, for instance, provided accelerometry data. And so we have to be extremely careful with, the question of privacy. I think there's a lot of complexity around it. Obviously, privacy is something we want, but do we want it all the time is a good question. If you were offered, for instance, to participate in a study where your facial data and your voice data that are both considered biometric identifiers could be used to potentially help you diagnose early onset of disease that could then be prevented. And then, you'd also be contributing to an important research project for humanity. Would you actually decide to keep the data to yourself and not share it? Or would you want to participate? I think this is a very individual question, and it's really hard for us to know what, the general population would say. But clearly, the problem with voice and speech in particular is that it is probably possible, not quite in the immediate, but at least in the future, to link up pretty precisely those data to individuals. And voice print is currently considered a biometric identifier according to HIPAA, which is a big barrier to research. But I'm sure, Dr. Bensoussan, you have more to add.
Yes, I think this is fascinating because the important thing that also we're trying to tackle with our group at Bridge to AI, and we have a fantastic group of bioethicists, is try to help regulate these important concepts. So as Dr. Rameau explained, a voice print is considered an identifier from HIPAA law that's from the 90s, right? There's no clear description of what a voice print is. So it's a gray zone there. So because of that, some of our institutions will allow voice to be collected. Some institutions don't even say that voice is an identifier, and others will say you cannot sharing in any form, even if you have a data use agreement. Okay. So a lot of our work has been motivated by that. And so what is a voice print? It's from the HIPAA law from the 90s. There was no technology to hack as much as we have today, right? So we really need an update on that law, specifically understanding what part of voice and speech is. So, for example, is a maximum phonation time. Can you re-identify someone based on your maximum phonation time, right? A prolonged vowel, or can I train on that? Obviously, if you have a open question and you have somebody talk, then you can have them talk about where they live or give information about who they are, and that could be re-identifiable. But I think it's really important to make the distinction within voice and speech what are true identifiers versus what we can share to be able to say, well, we want to open the database as much as we can to be able to fuel discovery while maintaining privacy. And it's fascinating. To be honest, when we applied for this grant, it was 2.5 years ago. We thought we could do an open source database and everything would be public. And as we are going through our ethical inquiries and collecting more evidence based ethical data, we're seeing that we'll have to do a lot of restricted access on some part of the data. And it's really in keeping with other big projects. So when you think about large consortiums like all of us that have tons of data, health data on patients, the Human Genome Project as well, they're starting to put boundaries to how they share their data because the risk is high for the patients.
I appreciate that. And like you said, I'm sure there's going to be potential participants that will consider different studies and have that concern. Any prognostication on how we maintain privacy? Like what, as hacking has evolved, I mean, it's sort of a race with security as well. How optimistic are you that we can keep things as private as possible?
We can look at the literature and it shows that a lot of things are re-identifying, even EKGs. If a hacker is very motivated, can re-identify you based on your EKG. So we have to be careful at not providing too much data, but we know that if hackers are very motivated, they're going to be able to do pretty much things that are very difficult to do. So there are a lot of methods that are out right now for de-identification of voice. You can modify the sound. There are a lot of methods to remove information that the patients say that could be identifying. So it's a lot of different ways that you can quote unquote de-identify the data. Or other methods that are more standard is extracting features. So when you extract, for example, amplitude, jitter, shimmer, these are things that are not identifying as much as the raw sample, but where you can definitely still conduct research. So that's kind of the first layer. The other thing that we're working on with our group is federated learning. It's a solution, it's a type of machine learning where you don't have to share the data, but you can develop algorithms and models to train on data that you don't have. So then the data doesn't need to be shared, but you can still run models. So that's a kind of another layer of privacy protection. But at the end of the day, the best database will have to contain raw data because today we analyze data with mass spectrogram, we analyze data with acoustic features. In 10 years, the technology might change, and the researchers in 10 years will need to have access to the raw data to be able to make discoveries.
Yeah, thank you for that. Earlier in our conversation, we talked about the concept of omics, like general omics, right? So the listener may have heard about radiomics, proteomics, genomics. Now we're talking about audiomics. I think it really speaks to the multidisciplinary approach to this data. But can you comment on the unique opportunity as otolaryngologists that we have and speech scientists to refine this field, this kind of emerging or actually field that is being refined as we speak? Yeah, how do you see this opportunity as we move forward?
I think both Dr. Bensoussan and myself really ascribe to multidisciplinarity and really love working with people with different fields of knowledge and expertise. And I think when you're tackling such a new endeavor that's really breaking the boundaries of laryngology and really pushing our field into a much bigger space, you got to accept to work with people who have different knowledge because you have to have people criticize you. You need to understand the implications of the technology you are working on. And also, the complexity of the science really requires talent that is multidisciplinary and really involves both engineering, physics, linguistics, social sciences, ethicists, you name it. I mean, this is very, very broad and very exciting, actually, especially for those of us in ENT who've had other hats in their past. It can be really exciting to think in different ways and broader ways.
Yeah, you can't approach this with a fixed mindset, right? I mean, I don't want to speak for you, but I feel like it's very energizing to get out of our silos and see how what we do has a broader or different impact.
I would just add a very specific example that happened to me a few weeks ago to really tell people to not be shy and value your expertise, right? So, a lot of ENTs tell me, well, I don't know, I'm a little intimidated by AI. How can I contribute or how can I learn? And the value of your expertise as a clinician is huge. So, to give a easy example, we're running some models for Strider. Right now, I work with a very, very talented data scientist, AI engineer, brilliant. And we record some of my patients with Strider and he annotates them. And I gave him a crash course on how to annotate Strider. And he got a model in the accuracy. And then we went into the validating, right? So auditing what's happening. And I listened to a few breaths that he coded as Strider, but it's actually nasal breathing. So it was just the nasal sound from inspiration. And as a clinician, I hear it. I know exactly that it's nasal airflow. But for him, he's not a clinician. He had no idea. So all his algorithm would have been completely biased because he was annotating nasal airflow as Strider. And I mean, this happens all the time. And when data scientists don't collaborate with clinicians, then their models are often not accurate, right? And vice versa. So we really need each other. And it is harder to work together than individually, but the result is so much more impactful.
Well, I really appreciate this conversation. I know our listeners will too. Before we conclude today, for anyone listening that is interested in this field or even other parallel things with AI and machine learning, can you guys recommend, what are some great like foundational things that might provide the listener with just a little more background or easy entry point to sort of expand their knowledge?
Sure. So I let Dr. Bensoussan mention some of the resources that Bridge2AI is creating. But in the meantime, I wanted to mention some of the amazing resources that actually JAMA is putting out. So JAMA has a whole section on AI, and I love following those sections. There's some really great ethical discussions, but also simple articles that just help you read through an AI manuscript. And I think that, we need to engage with that literature and have a critical insight. And it's very, very important that everyone becomes familiar with that. And then finally, the other resource I'll mention is the Stanford Human-Centered AI group that actually has a lot of really great educational material, and everything is open access.
I'm just going to add to what Dr. Rameau just spoke about in terms of our resources, because one of our mission also is to educate the public on voice AI. And we have a webinar that's monthly that is open to the public that you can find on our Bridge to AI website. We're going to have a voice AI summer school this summer with a hackathon and our voice AI symposium. Everybody is invited.
Well, that is awesome. I wanted to just, as a colleague, congratulate you both on really pushing the field forward with this amongst your other accomplishments outside the fields of AI. And it's been a real pleasure to have you both on the podcast. So thank you both.
Thank you.
Thank you so much.
This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.